Imagine trying to operate deep inside the brain without a roadmap. You could have done this 1,000 times before, but in the back of your head, you remember every brain is different. For decades, that was the challenge neurosurgeons faced. But the story of image-guided neurosurgery is really the story of how we built that roadmap and how it continues to evolve. Let's start at the beginning. The origins trace back to stereotactic radiosurgery in the early 1900s. Surgeons developed rigid, coordinate systems and brain atlases to precisely target deep brain structures. By the 1940s, stereotaxy was being used to treat movement disorders with remarkable accuracy, even without modern imaging. Fast forward to the 1990s, and technology transformed everything. Advances in computed tomography, magnetic resonance imaging, and computing made it possible to merge pre-operative scans with real-time surgical anatomy. This was the birth of Neuronavigation, a GPS system for the brain. Suddenly, surgeons could plan a safe trajectory, track instruments, and verify positions with submillimeter precision. So how does modern neuronavigation actually work today? It follows a clear stepwise process. First, preoperative imaging. A high-resolution MRI or CT scan is acquired, often with contrast for tumors or vascular lesions. Then we have image transfer and registration. These scans are loaded into the neuronavigation system and registered to the patient's actual anatomy using fiducial markers or surface matching. Then 3, we have trajectory planning. The surgeon marks the lesion or target and plans the safest approach, avoiding eloquent cortex, white matter tracts, and major vessels. 4, then we have patient positioning and setup. The head is fixed, or in some systems, frameless tracking is used, and the navigation system is calibrated in the operating theater. Then we have intraoperative guidance. As the surgeon advances instruments, the system continuously tracks their position relative to the preoperative images, like a GPS cursor moving along a planned route. Then we have verification and adjustment. The navigation helps confirm the lesion has been reached and the margins are respected, and critical structures are spared. And most importantly, we have documentation. The navigation system often records trajectories, biopsy sites, or resection margins for the surgical record. Clinically, the applications are wide-ranging, from tumor resections to biopsies to epilepsy surgeries and even vascular procedures. But the field hasn't stood still. In the last decade, we've seen the rise of augmented reality, which overlays imaging directly onto the surgical field, whether for cranial tumor resections, spinal screw placement, or complex skull-base approaches. We've also entered the era of robotics, with systems like the NeuroArm, which is an MRI-compatible surgical robot that filters tremor and provides haptic feedback, and even allows remote operation. And now, we have AI and computer vision, which are pushing the boundaries further. We have Zeta Surgical cranial navigation platform, for example, which allows frameless, real-time navigation with sub-millimeter accuracy without the need for rigid head fixation. This might sound like a perfect system, but always note, every system has its disadvantages, and the surgeon is duty-bound to know them before using them. The implications of using these systems are profound. We've moved from purely mechanical frames to computers to immersive technologies and robotics, all in a single century. What began as a way to reach deep brain structures safely has become a cornerstone of modern neurosurgery. So, when we talk about image-guided neurosurgery, we're not just describing a tool. We're describing a century-long journey of innovation, one that continues to shape how we operate today, and one that will likely define the future of safe, precise brain surgery. Thank you for your attention and have a blessed